Thank you very much for that kind introduction. And, to fill in for Dr. Wagner is filling in big shoes. So although I don't have big feet, I do have fancy shoes. So we'll take it and go from there. And thank you for this opportunity to present today. And we'll talk about Fanconi anemia, which is my favorite subject. If this moves. I can keep talking. I don't need to, but there are nice pictures here, so I think it will be useful. All right. So we know that our DNA is constantly damaged every day, whether it's ultraviolet light, whether it's radiation, whether it's pathogens, anything. And in our body, there are mechanisms that are set in to repair these things, as shown here. There are DNA damage, checkpoint DNA damage, repair mechanisms. And when these things actually don't work, if there is defects in any of these repair mechanisms, then what results is chromosome instability syndrome. And Fanconi anemia is one of these syndromes. Before I talk more about Fanconi anemia per se, I just wanted to briefly discuss normal hematopoiesis. So a lot of the basic scientists know this, and some of the clinicians also know this, but just for review, we know that stem cells, they live in the bone marrow with the microenvironment. They have the ability to do the self-renewal, as shown here, and also they form the progenitor cells, as shown in the middle, and then that eventually leads to the mature blood cells that we see normally. Now, the hematopoietic compartments, again, the stem cells makes multipotent progenitor, then it makes the common lymphoid progenitor and common myeloid progenitor that subsequently lead to the right side of the diagram where all the mature blood cells are formed. And this is what the blood cells look like. You know, there is a band cell here. I don't think this pointer. But the band cell on the left, the neutrophil, there is a basophil in the middle, and the monocyte. So this is what the normal blood cells, blood smear looks like. So what does abnormal hematopoiesis lead to? Well, abnormal hematopoiesis leads to decreased production of either all of the cell types that we just reviewed, or one cell type. So it will lead to either single lineage cytopenia, what we call, or aplastic anemia. Sometimes abnormal hematopoiesis will lead to abnormal proliferation, differentiation, apoptosis, and that leads to myelodysplastic syndrome, or AML, which is acute myeloid leukemia. Now, Fanconi anemia is a disease where you're going to see all three of these characteristics. So what is Fanconi anemia? Most of us are here because we know what's Fanconi anemia, but it's a rare autosomal recessive, for most part, B is the X-linked disease disorder, which is characterized by congenital malformations, progressive marrow failure, and predisposition to malignancy. So at least 16 separate genetic defects lead to reduced ability to repair DNA damage, as we reviewed. And this is usually, as we talked about, transmitted as autosomal recessive. What does that mean? It means it's very simple that mother and father carry the abnormal gene, and there is 1 in 4 chance that the child will have Fanconi anemia, as shown here on the right. So common features of Fanconi anemia are clinicians who see these patients regularly are easily able to recognize some of these features, and also that not all patients will have all of these classic features. So here, as shown here, these patients are short. This patient here is short. This is the classic picture. Every Fanconi talk has his picture, so we thank him for that. And as you can see, if you pay attention, his thumbs are a little dangling. On the facial features, there are certain subtle things that you can observe. So there's depressed nasal bridge. There's an increased distance between the two eyes. And there is a triangular face with pointed chin, somewhat of a low-set ears. Upper extremity abnormalities are very common in patients with Fanconi anemia. As shown here, they can vary from no abnormality to all of these varieties. Thumb abnormalities, radial reduction, there is broad base, proximal phalanx, syndactyly, absence of lower arm. Skin abnormalities. Patients have what is classically called as cafe au lait spot. As the name suggests, the brown hyperpigmented spot is the cafe au lait spot. But to keep in mind that these patients also have hypopigmented lesions too. So look for them when you are seeing your patients. Kidney abnormalities are common. They can vary from, again, no abnormality to very severe abnormality of absent kidney on one side and rudimentary on the second side. The example here shows a horseshoe kidney and cross-fuse ectopia. It's a fancy name. Basically, two kidneys are on the one side. Other organs that can be involved with Fanconi anemia include essentially every organ system. So the patients can have structural heart abnormalities, external ear, internal ear abnormalities, bony defects. There is esophageal atresia, tracheoesophageal fistula, malrotation of the gut, kidney abnormalities, as we talked about. And on the right side of the diagram, as shown there, they do have endocrine organs involved. So thyroid abnormalities are quite common. Patients with Fanconi do have abnormal glucose tolerance, hypogonadism, and things like that. So here, essentially, we're seeing that the phenotype is very complex and it is quite variable. So these percentages tell you that patients can have a lot of abnormalities. What I want you to focus on is the bottom red, where it's important to recognize that almost 30% of the patients with Fanconi anemia will have no external abnormalities, and it's important to recognize this and keep it in mind when we are seeing patients and evaluating them for congenital marrow failure syndromes. So in terms of congenital abnormalities, there are still quite a lot of unanswered questions that we as physicians, we as scientists, researchers, that can look into. Why do they develop congenital abnormalities? Why are the anomalies so heterogeneous and variable? Even in the same family, you will have two siblings. One will have abnormalities, one will not. Even in the twins, there is a difference. So why is that? Is there some intrauterine factors? Is it causing this? We don't know, and that is something I think one of us should focus on and trying to figure it out. Moving forward to the second feature that we talked about for Fanconi anemia, progressive marrow failure. Marrow failure usually starts in the first decade of life, but again, that's not the rule. That's a median age of onset for marrow failure is about 7 years of age. Usually it's thrombocytopenia that appears first, followed by other cytopenias like granulocytopenia, anemia, things like that. Severe aplasia develops over a period of time of months to years, and there is no way to predict how long it's going to take for a particular child. As shown here, cumulative incidence of any hematologic abnormalities by age 40, and shown in the red, is almost 90%. So essentially, most patients will develop hematologic abnormalities over time. So this is what the progressive marrow failure looks like. On the left is the normal bone marrow. You see all the blue, those are the normal hematopoietic cells. Those are baby platelets, baby red cells, baby white cells that are going to make all the blood cells that we see on our CBC. On the right is the patient's marrow with aplasia, where the whites you see, and then there are blue in between those whites. Those blues are the reduced number of baby white cells, baby platelets, and baby red cells. The big white blobs that you're seeing is actually the space taken over by fat, which all of us are very familiar with. It's notorious to do that. It takes all the space it gets. Progressive marrow failure. Again, what causes this? It's still a matter of debate after after so many years of seeing patients, treating patients with Fanconi anemia, doing research on Fanconi anemia, there are different thoughts. People do believe that DNA damage repair in the stem cell pool has definitely a role. Are there other functional stem cell abnormalities? Or is it all driven by inflammation that causes stem cell exhaustion? Again, Dr. Mind will spend more time in explaining the basic mechanisms and going more into the science and biochemical pathways. But I wanted to at least bring it up that is something we are still trying to figure out. As shown here, over time, the stem cells, there is increased attrition of the stem cells, and there are reduced number of stem cells that causes progressive marrow failure. It makes sense. Now, why does it happen? As talked about it before, there are some inciting events that have been recognized as possibly causing it or adding to the damaged DNA. So oxidative stress is one of them. Aldehydes is also one of them, genotoxic stress, or inflammatory cytokines. So if you pick up literature, you will read all about it, and essentially it leads to sensitivity to stressors and signaling pathways. So when one other thing that happens is if, as shown here, the stem cells, when there is cell cycle arrest, cell death, there is senescence differentiation, it leads to stem cell attrition, so they cannot cross that path. So then they figure it out, well, I'm going to go another path, I'm going to go to differentiation, I'm going to go to proliferation, and I'm going to cause what is called as pre-leukemia myelodysplastic syndrome, or leukemia AML. So these are the common hematologic malignancies seen in patients with FA. MDS, acute myeloid leukemia. As shown in the picture, by age of 40 years, essentially 20 to 33% of the patients will develop either MDS or AML, which is significantly high compared to the general population. Myelodysplastic syndrome it's considered a pre-leukemia in common terms. It's a clonal disorder of ineffective hematopoiesis associated with increased risk of leukemic transformation. In FA, it's usually associated with complex karyotype or complex clonal cytogenetic abnormalities. It's important to note that patients with FA at baseline do not have bone marrow that look completely normal. So when we have patients' marrow being evaluated, it's important that the pathologist who is used to seeing marrows from congenital marrow failure syndromes looks at it. Otherwise, outside pathologists will call. We've seen patients where pathologists who haven't seen many congenital marrow failure syndromes have called patients that they have MDS. Parents are panicking. They come to us for transplant, and really the child didn't have MDS. So it's an important point to remember. Now, if you see obvious abnormalities, like as shown in the pictures, like micromegakaryocytes and things like that, that define MDS, then yes, but that's something important to review with the pathologist in detail. Again, clonal abnormalities I mentioned before are the common chromosomal abnormalities seen in patients with FA. So chromosome 1, 3, and 7 are the most common abnormalities seen in patients with FA. This was our data from Cincinnati that we had reviewed, looked back into what our patients showed. And the point I'm trying to make is that having a clone doesn't necessarily mean that it's bad. As shown here, in patients who had chromosome 1 abnormality versus patients who didn't have chromosome 1 abnormality, there was no difference in progression to myelodysplastic syndrome or AML. So practically speaking, when I have a patient with Fanconi anemia who has a 1q abnormality, it's absolutely fine to watch as long as there is no dysplasia, obvious dysplasia on the marrow. As against that, well, In contrast to that, chromosome 7 abnormality, especially monosomy 7, is notorious to progress to acute myeloid leukemia or high-grade MDS. So those we really take seriously, and we start preparing for transplant and call as soon as they turn into MDS. In our study, 3Q did not pan out to be significant because there was not a long time for follow-up. But the German group has been the first one to bring up that 3Q is bad, and over time, I think all of us have come to agree that just like 7, 3Q abnormality in a patient does draw our attention and ask for intervention. So something to keep in mind, because these clones will progress, will lead to acute myeloid leukemia, and when it does, this is what it looks like. So on the left is a normal bone marrow. You see all the cells are of different sizes and shapes, and on the right is the leukemic bone marrow, where all the cells look same. So this is how the blood smear looks on the patient, and especially for the researchers in the group. So the third thing that we talked about, when you say increased incidence of malignancy, there are also common solid tumors that patients with Fanconi anemia have an increased risk to. And these are squamous cell carcinomas of head and neck and vulva and cervix. As shown in the figure again, by age 40, almost 30% risk, 30% cumulative incidence of squamous cell carcinoma. FANC-D1 is a special subgroup. BRCA2 patients actually develop other tumors too. They develop these tumors, unfortunately, early in life. Neuroblastoma, medulloblastoma, and Wilms tumor are common. And because we know this already, anything we know, we try to prevent. So we do have guidelines in place that these patients do get screened every 3 months with ultrasound, making sure the kidneys are okay, looking at their brain scans, things like that. Also, it has implications for their parents who are heterozygote carriers for BRCA, and we all know that BRCA2 is the breast cancer-associated gene, and they do have formal standard guidelines that they need to follow for their own risk of breast cancer, ovarian cancers, prostate cancer, pancreatic, and others. The other thing that we have to keep a very close eye on is the issue of secondary tumors related to the exposure of radiation that we used to utilize in transplantation, and some centers still do. The difference between Fanconi head and neck squamous cell carcinoma and head and neck squamous cell carcinoma seen in non-Fanconi patients is very nicely shown by Bhuvnesh Singh in the FA guidelines, the last one in 2008. If you look at the incidence by age 40, their incidence is significantly higher, 14% versus 0.038. They do get these tumors earlier in their life, which we know. And also, they do get secondary primary tumors, so there can be multiple tumors in one patient without using the tobacco and alcohol. The adults use tobacco, alcohol. Our kids, they know the risk, they're higher risk. They try to avoid based on our advice. But despite that, the risk is significantly high, and we need to keep that in mind when we're taking care of these patients or planning their transplant or planning their other treatments. Again, standard treatment for non-FA patients will include all 3 modalities: surgery, chemotherapy, and radiation, while FA, because of the sensitivity, can only get surgery. So our hope is that if we can figure out how to prevent this, would be really nice. So one important thing is to keep in mind is some patients will present with clinical symptoms and signs or malignancy for the first time as an adult. You look at the, 6.5 years is the median time to develop marrow failure, but look at the age range. There are patients who presented for the first time at 20, 25, 30. So I think the important thing is to keep in mind that you need to keep a very high index of suspicion for congenital marrow failure syndrome, and if you're worried, please think about it and send a test. So how do you diagnose Fanconi anemia? The gold standard is increased chromosome fragility, which is shown by exposure to DEB or mitomycin C. And here's an example how it is diagnosed. On the left is the mitomycin C, and you see normal patients, as the concentration of MMC increases, they will show decreased growth, but Fanconi patients have more sensitivity, and you will see the decrease in the growth. On the right, or my left and your right, yes. Chromosome breaks. You see when mitomycin cells are exposed, you will see chromosome breaks and rearrangements. And this itself, the test itself, tells us a lot about what we should expect in terms of clinical phenotype. This shows that patients are going to be sensitive to chemotherapy, certain chemotherapy. Now, DEB is also, as I said, MMC, and now DEB is the standard of care to diagnose FA. On the left is the normal control, so normal chromosomes will look like this. You have the FA control, somebody who already is known FA patient, and this was my patient whose chromosomes looked like the FA patient, and that's how once it was exposed to DEB, it showed all the chromosome radials, rearrangements, and was diagnosed. This was an 18-year-old who presented with MDS and was taller than me, 6 feet, and bigger than me. He was the valedictorian of his class, no congenital abnormalities, came to me to transplant for MDS, and the standard of care would have been busulfan Cytoxan. If he had showed up at University Hospital, that's what he would get. Luckily, on history, he had an extra thumb tag or skin tag at the hand that was removed at 2 years of age, and he had a tag here that was removed. That history helped us, and again, we do have a standard practice because we see patients with FA to look for marrow failure syndromes in our MDS patients, young MDS patients. But very important point to keep in mind that these patients will get missed, they will get mistreated, and which can be life-threatening. Again, complementation groups, we know that now every year, essentially, we are seeing one new complementation group, which is great. But again, this is not the full list. I think this has 15, and now we know 16. But I just wanted to put it out there to show you that, the common ones, if you look at the figure, the common one is the A, C, and G still, but we do have other more and more new mutations being found. And on the left, you see the strategies that were utilized to identify each of these genes, and I will leave it up to Dr. Hine to explain that more in detail. So once we've diagnosed the patient, we need to take care of the patient, and it takes a lot of teamwork, organization to care for these patients. They are special, and they need special treatment. So what are the treatment options for patients with Fanconi anemia? Essentially, it's watchful waiting, following the counts, and following any clinical symptoms. At the stage of early marrow failure syndrome, are there any options? Well, for years, we've been doing some stem cell collection, whether for reinfusion, whether for gene therapy, also, some of the newer experimental therapies may be applied to the early marrow failure stage. The important thing is that we know that over time, the stem cells are going to deplete. So whatever intervention we think we want to do, probably is a good idea to do it at early marrow failure stage or even before that sets in, so that we've not lost the stem cells by the time we try to act. Now, so this is just briefly, we know we've talked about gene therapy, and we're trying to improve, and we hope we get there. But essentially, it's genetically corrected patient cells for transplant. And the advantages are there is no donor search, there's no GVHD, essentially no conditioning, or some. But it has its own challenges. That's why we haven't, have clinics for gene therapy at every FA center so far. But, the challenges are limited stem cells are collected. When the patients are being collected, the stem cells are not enough to be able to utilize for the whole transplant. The gene correction efficiencies had issues, and that is being sorted right now. There were issues with insertional mutagenesis in the SCID trial, so we need to be careful about this. We don't want to cause any harm. What happens to the cells that are sitting there for over time? Do they actually do anything in the freezer? We don't know that. So anyway, moving on to the treatment for moderate marrow failure, for last 30 plus years, what we've offered to the patients is potentially just choice of androgen. Now, androgen only works in 50% of the patients, and it is associated with side effects. Causes liver toxicity, virilization, hepatic adenoma, or carcinoma. I'm not saying it's the worst thing in the world. We have patients who've been on androgens, very stable for a long time too. So again, this is an individualized approach, not one hat fits all. So it depends on where they are, what their donor search looks like, what their options are. So they do work. When it works, they do work. I have patients who've been on it for a long time and they're doing fine. But just if you look at numbers, that's what you will see. Also, at that point, the patients can be supported with GCSF if needed, and it's safe to do that. About androgens, so what does it actually do? It stimulates the red cell production and also may improve platelet number and sometimes neutrophil counts. But how do they actually work? Nobody knows. So this is another question for the research room is, we need to figure out how they work, because clearly they do work in patients, and we don't know. So something to think about. Treatment or other options. So transplant is the option for severe marrow failure, patients who have developed MDS or who have developed AML, whether it's related or unrelated donor transplant. Now, issues with transplant are, we talked about, the FA cells are extremely sensitive to DNA damage, alkylating agents, radiation. They do get higher toxicity compared to patients who don't have Fanconi anemia. This was originally seen when traditional doses of chemotherapy were used by the French group in 5 patients, and 4 out of 5 patients died. It was unfortunate, but that actually gave us the clue that these patients are very sensitive. And that the same group then went on and showed that they're also sensitive to radiation. So you cannot use 200 per kilo or 1200 of TBI in a patient with Fanconi anemia, what you can easily use in a patient who has ALL. Anyway, for a long time, the survival was into 20 to 30% range. And then came fludarabine, and it's a highly immunosuppressive agent that helped reduce the risk of graft rejection without adding any major toxicity, which was great. And over time, different groups tried different combinations with Cytoxan, ATG, and low dose of TBI, and we saw improved outcomes of transplant, around 70 to 80% in good risk patients. So what are the challenges with transplant? They are not without challenge. I'm a transplanter, I love to transplant, but we don't take patients to transplant unless they really need it because of these reasons. So for specifically, if you look at FA, FA with high-grade MDS and AML, the question of whether there is pre-transplant remission induction, do they need it? Do we need to do it? Well, I am the author of one of those papers, and we've looked at it, but it has its own issues, and it doesn't necessarily, we're not looking at remission, you're looking at cytoreduction and taking them to transplant empty. So it's essentially, you're saying, it's helping but not curing. But the question is, should you do that, or should you focus on post-transplant intervention? And I think there is a lot of data and a lot of role to consider that instead of the former two. Again, older patients with FA, they tend to see more toxicity and need individualized approach. Issue with transplant, not everybody has MET-CIP, we know that, but also not everybody finds an unrelated donor marrow match. Based on your ethnicity, I may not have a high chance of getting a match if I need bone marrow transplant. So we need to have transplant strategies that will accommodate for mismatched family donors, utilization of mismatched family donors safely. The other issue, again, obviously, with transplant is toxicity. New regimens are needed to decrease short-term and long-term side effects of BMT. So common long-term side effects are the organ toxicity. You're looking at cardiopulmonary, liver, renal, endocrine growth, gonadal thyroid dysfunction remains an issue. So that's why these patients post-transplant follow very closely by endocrine. Graft versus host disease, chronic graft versus host disease is not a fun thing to have, and it has associated mortality and morbidity. And most importantly for this population is the risk of secondary malignancies. Patients with FA have increased risk of secondary MDS or AML and solid tumors because, one, they have a baseline increased risk. Second, they get exposed to chemotherapy just like everybody else. They get exposed to radiation, which they are sensitive to. We also see oral and GI tract damage from mucositis or chronic GVHD. So the effort should be made to try to address each of these issues to decrease the risk of cancer post-BMT. So overall, the way I think about treatment options for FA, what we've done for years is at the time of diagnosis, we have been smart enough to have comprehensive care clinic. We've been smart enough to do complementation. At the point of early marrow failure, we've talked about collection studies for future use. Moderate marrow failure, we've used androgens, and for end-stage disease, we've used bone marrow transplant. However, we do need new therapies which are preventive and therapeutic and which have better toxicity profile. We haven't made a whole lot of progress in many years. So what we've been able to do now at diagnosis, we've used to do complementation. Now we go to sequencing. We have the gene defect identified. We have the mutation in our hand that helps with early and improved risk assessment and counseling, both for the patient and the parent. For example, I gave you for the BRCA2 family. Also, patients are referred early, and at the time of the first contact, we make sure we do the HLA typing. So we have identified a potential donor early. We're not scrambling for a donor if patient develops MDS or leukemia. So those are some of the good things we're doing at diagnosis. What about at the stage of early marrow failure? We have improvised and optimized gene therapy trials. We are still working on them, and I really hope that we continue to make significant progress there. Other things we can explore, target the novel etiological pathways that we have discovered. For example, the reactive oxygen species. We should target that. And I will do the shameless advertising that we have done that in Cincinnati. We do have a phase 1 study that's open of an antioxidant in patients with Fanconi anemia. We need to target aldehydes. We've been talking about it for 3 years at least. We need to do that. So try and find targets which are new, which will have less toxic therapies. Moderate marrow failure, use of newer androgens with less toxicity, so that is good. And what about the last stage, end-stage marrow failure? So the issue of radiation that I talked to you about. So we have radiation-free transplant regimens now, and I will be presenting the data on Saturdays in detail, so I won't go in detail now. The other thing to think about is to minimize toxicity of the other agents. It's not just radiation, but what about other chemotherapy? You want to do pharmacokinetically directed drug dosage, not just, and we do that for busulfan when we've replaced TBI with it, but we need to do it with other chemotherapy agents too. Why not? We don't know whether 40 per kilo of Cytoxan, what it's doing. And maybe we can get by with 20. We don't know that because we've never looked. Improved BMT outcomes for older patients and those with MDS and AML by personalizing their transplant. So how do we achieve all this and more? And the answer is research, research, and research. And also bench-to-bedside collaboration. That is the key. The researchers in this room and the clinician in this room are put together for a reason, and this is what FARF is trying to do, is put all of us in this room and close the door so that we talk to each other, and that is the key to make any progress in this disease or any disease which is rare like this, where we don't have the registries, we don't have the children's oncology group where we can enroll 1,000 patients. And again, just to give you an example, this is what we've adopted. This is all some of my studies, and at CHMC, this is what we are following. So, for example, for marrow failure, we collaborate with Kishan Peng and Paul and Ruhi on leukemia predisposition. We have a couple of collaborators in our experimental hematology who are experts in mouse model of leukemia and MDS. And in terms of predisposition to solid tumors, we have collaborative studies with Suza Wells and Melinda. And also, I put Farid Boulad there because we are part of the multi-institutional study avoiding radiation, which we hope will decrease the risk of solid tumors in these patients. And these collaborations, and I'm just giving you an example, have truly led to some meaningful outcomes. It's not just a triangle that looks pretty on the slide. It actually has affected the patients. So to give you an example, I told you about Kishan Peng. Quercetin, we have a study now, as I told you, of antioxidant based directly on Kishan's data in mice. So we have a phase 1 study, which is actually federally funded, which is great. We are also looking at origins of monosomy 7 in patients with and without marrow failure. And having a repository gives us the ability to actually go back in time on patients in which we have serial samples to say what exact time point the switch flipped from being okay to being monosomy 7 or any other clone positive. Things like that. You can find novel partners which are collaborating with 1, 3, or 7, or there are so many other partners that they actually start, and 1, 3, and 7 come late, but that's the only ones we know. So things like that. Looking at solid tumor prevention, we did a serology as a biomarker for immune response to HPV vaccination study that was funded by FARF. So again, the goal is to address almost all the questions that we have, the patients have, and the parents have, as much as possible. Okay? Thank you, and I'll take questions. Yes, I can talk about it I have 10 minutes. I gave a talk last year about it. But yes, it's a very interesting question. I think the jury is is out on the role of HPV in NFA. We do have some of the basic data from Souza's lab showing that there is a role of HPV in NFA. Melinda Butch-Kowalczyk is doing the oral rinse studies where we are seeing some positivity. However, as you are aware, the two data, the Cutler paper and the Netherlands paper, are contradictory in terms of Unica can answer more, but in terms of positivity in the tumor itself. I think we need more data, more longitudinal data to really answer the question. I don't think anybody can say for sure either way.
So our paper on HPV is also out. We studied about 9 patients, tumor samples.
On the vaccine, yeah?
Yeah. And,
tumor samples, yes.
Yes, and we found that the HPV prevalence was not increased.
Yes.
So in our patients, we didn't think that HPV played a role in causing the cancers.
I agree. That's what the Netherlands papers showed too.
Also, I'd like to ask people to, even starting tonight, to please just introduce themselves extremely briefly when they get up to ask a question in the spirit of community building and people getting to know who's who and who has what information. That would be very helpful.
So I'm Neelam Giri from National Cancer Institute.
Thank you.
Other questions?
All right, great. Thank you.
So the question I would like to ask to Parinda is what we have been observing for a couple of years, especially from brothers and sisters that sometimes have the same mutation and still develop such a different clinical picture. I talk a lot with Nick as well, because we have so many brothers and sisters around the world, and we could try to get them together and see what has triggered. We have patients that develop bone marrow failure at the age of 7, while their brother or sister develops myelodysplastic syndrome at the age of 22. So they live in the same environment. They are usually exposed to the same pathogens. I really don't believe that they have so many different infections to trigger something. And what makes one develop such a different course if they have the same mutation? And what really triggers bone marrow failure in these patients?
I'm with you, and I'm asking the question to Dr. Mine. No, exactly. I don't think anybody knows, at least that I know of, I'm aware of. And we've seen this all the time also. I've had a patient who'd had relapse MDS and progressed and unfortunately died, a teenager, and whose brother was just 2 years behind him, but and he said, I'm not going to take any medical care because this is exactly what's going to happen to me. And but it's been 8+ years, and he's fine without any medical care. I'm not advocating for it, but I agree. I don't think, at least I don't know the answer, and I think we do need to think about it.
So it's a very interesting question. I don't think we have a firm answer for it, but if you want to think about possibilities, so if you say you have 2 siblings who have very disparate phenotypes in terms of age of onset or severity or the different pleiotropic effects of Fanconi anemia, you have several options, one of which is to say it's genetic, that it's some difference in genetic modifying genes besides their shared Fanconi alleles. Another possibility is the environment is somehow different for the 2 of them, even though they may be in the same household. And so you're free to speculate what that might be. And then I think the other issue is there a stochastic somatic effect that you're looking at? And that for whatever the nature of the etiology of, say, the bone marrow failure, there's a fair stochastic component to it. So everyone in this room is free to speculate as to your favorite mechanism that might fit into those, but I think those are sort of general parameters.
So Steve may have some thoughts about this, but one question would be, given the size of the community and the model of linkage analysis, whether one could actually take it on in terms of a computational and algorithmic approach. I mean, could you actually consider, at least for the genetics, which is probably the only thing where you could generate the data to do it, could you actually do a matched pair sort of thing where you actually took pairs who had very similar clinical courses and those that were discrepant and address that from a computational perspective?
It's certainly possible these days to get information in terms of, say, exomic variants, so coding variants would be easy. The question is what you would do with them. And I think that may actually be the challenge, because you're free to look at, if you do, say, an exome, you're going to have several 100,000 variants. And so you have to have some way to sort them out, either hypothesis-driven comparisons, or the hope that if you do enough of these pairwise comparisons, something may fall out. But I think that you're probably not looking for rare variants, you'll probably be looking for polymorphisms.